Okay, so this is about module 2 and the residence rights, and I'm going to go ahead and jump in from slide to slide here. So going back earlier to the different needs, I'd like to summarize it further about food, water, and all these the physiological needs are the basic needs. And then you also have the safety and security needs, which talks about freedom, fear, and also mentioned about pain. Now, they also have the right to love and express their affection because they need to have a sense of belonging. As a matter of fact, people at the facilities, they can also have a residence council. And what is that is, am I showing my screen? Can you guys confirm I'm showing my screen? Yes. So what does that mean is they are able to express their complaints, their grievance, their joy, or whatever it is that they want to be changed or given attention at the facilities. We don't like the food here, or we would like to have a cultural week every month, wherein, for example, we feature this month's going to be Mexican heritage, and they have some Mexican food items in there as well to be included in their diet. They can also have, okay, so this week, that week will be Filipino, the following week will be Vietnamese. So it allows them to have a connection with their culture, which is, I believe that's still a valid concern from the patient. So for them to be able to express that is they meet together with the administrator, the director of nursing, and maybe even the dietitians and people in the kitchen. So they know what to prepare and how is that going to happen. But anyway, they have the ability to have uh, receive families and friends and visitors. And when we let them to experience that, we actually designate a location that and they can have this privacy, and then that way. So the next one is to kind of summarize that the self-esteem is we ask them also to what they think about things that they experience or what's their opinion, and that's why we really listen to them. So we give them that dignity and giving respect and approval or recognition. And then the last one we talked about earlier was self-actualization, that take pride in the accomplishment that they do. A drawing could be a puzzle, could be a painting, could be a plant that's blossoming or would have flowers in there as well. They can also express that through a ecumenical event where they can gather in one room on a Sunday where there is a more like a religious leader. Doesn't have to be a Catholic priest or a born again Christian pastor or an imam or any type of ministers. You just have to someone that can cuts across regardless of what your religious belief. So you can be in one corner, do your own thing. You can be in one side, open your own Bible or Quran or whatever it is that you believe, the literature. Okay, so moving on, this is going to be more focused on the residents' rights. So as you can see there as well, it's pretty much the same in what you have in your paper book, more particular, to be fully informed as the evidence by the patient's written acknowledgement prior to or to the time of admission during and the stay. So what it basically meant here is every time that there's a new admission, the patient needs to be aware what is stipulated in the rules and the governing guidelines. What is the movie time? What is the visitor? What is the lights off time? What the usual time that they can have their breakfast or lunch? What's the usual time that they can go out and see their family members? Those kind of things had to be really clear upon admission. And they will have to affix their signature. Okay, yes, I'm fully giving my consent in this situation. So they need to know at the very, very beginning. So it's called their Bill of Rights. So again, the Bill of Rights is going to be given at the very start. Now, to be fully informed prior to at the time of admission and during stay, what are the charges? And at this point, it's going to be talking about how much is the charges. So how much is it going to pay? And I think yesterday I mentioned it ranges from 7,000 to maybe even 1,200 a month, depending on the condition. Maybe this resident has many different complications versus another resident who just only have maybe minimal conditions. So that means that person requires less attention, less doctor, because what they pay for is the room and board, food, and all the amenities and their nursing help, and maybe even including the doctors and medications, things like that. So that's why their charges could bloat up compared to other people in the facility that they may not need a lot of professional help. Like, for example, there's some people who need a therapist, then, well, they get extra payment for that. So that's when it will give them a much higher than other people. So, but anyway, they need to be aware which is not covered, which is covered. For all you know, toiletries, well, for free. But of course, your family members are not happy with the generic shampoo, and that shampoo can also be conditioner. That conditioner can also be a body wash. So it is multitasking type of toiletries. So your mom could have dandruff for using that, so they can bring their own favorite shampoo. And when they do, make sure they label that so it can be mixed up with other people, which is great. And then maybe even clothes. So not always your family member is going to be wearing gowns. They can also have their own personal favorite clothing or brand. But of course, they will have to make sure there's a signature or a name, so we know who to assign that when they are washed. So another one I'm showing here is to be fully informed by the physician about, this is talking about total health status. So is the condition of the family member, is it improving or declining? So they can decide, maybe we have to switch or we have to um, explore other approaches. Maybe the actual pill is not going to help. Maybe we need to introduce other methods of giving medications. Or maybe it's not the medication itself. Maybe she just needs to get some sunshine, or get some fresh air. Maybe she needs to get busy, look around for people, and that they're living objects moving. Maybe they just need some people to talk with. And that's all therapeutic in itself. Maybe we just want to get busy, having plants, watering the plants, talking to the flowers, and getting some nice, calming music. That'd be awesome. Versus a neighbor who is screaming for pain, another neighbor has some issues and throwing things and becoming loud or becoming unsettled. If you're in the middle of that room, then very less opportunity for you to have a more productive, more positive type of environment. So what's going to happen to your patient? That it's going to be difficult for them to advance and progress given that type of atmosphere. You guys know that too. So all those positivity, they need that. So if you can imagine, if you don't get some sunshine in a week's time, that's going to be sad. Of course, you don't have much good amount of vitamin D because we derive our vitamin D with the help of the sunshine, that kind of thing. And also, it gives energy. Getting bleached out there. Some people really do their best to get some sunshine, or at least to see moving things. Or at least they see the grass grows. Not really monitoring inch by inch the grass growing, but get to see the greens, the leaves are flying, and birds and things like that. It's human phenomenon. We need to connect with nature. And if you don't connect with nature, and you're always going to be staring at the ceiling, and you just have to deal with bunch and many different types of medication, injections, IVs, and all of that. The smell, the noise, and the general energy in that facility could be drowning instead of really therapeutic in itself. Those kind of things, my friend. And so we would like to be that person. And then here comes the staff workers, could be a nurse or a CNA. They have their own problems too. They're all busy and they're all tired and they're all beaten and they're all already, say, burned out, if you will. And what do you expect for them to the type of care that you will receive? All the more, they're less quality care. Plus, they dump them with X number of patients, more than that is a required amount per average in a ratio between the patient and the staff member. And some of them complain about the pay, some of them complaining about how they're being treated by the management, some of them complain about the coworkers, some of them complain about equipment not working properly, or some of them complaining about some of the linens are not ready, or maybe the trash bins are full and they cannot put more. Those kind of things. So it adds up, not just on your own personal thing that's going around you, but also the people who are supposed to be helping you also have some type of degradation, if you will. So when you or your patients go on I would say, an appointment with a doctor, make that person be honest with the physician. What you don't tell the physician, then the physician, the doctor will not be able to give that person the correct medication and the correct amount of medication. So this is very, very important. So honesty will be helpful. So what you don't show or what you don't tell, then it will not contribute to the resident's well-being. So the number four, we already mentioned a little while back, scrolling down the definitions: to give consent or to refuse any treatment or procedure or participation in experimental research. So what does that mean? For example, like I said, I mentioned a little while back when so Stanford Research Institute, that those are the outfit, and that they came to me and then they spoke with me and then they were asking if I can help. So I provided and gave them my plasma. And so the residents can also refuse medication. They can refuse food. They can refuse bath. They can refuse care. No, I don't want to. I don't want you to take care of me. I just want to go to shower. I just want to go to sleep. Leave me alone. Yes, they can also do that. We cannot force them anything that we want them to do. However, the good thing is we will document that. Well, how to make sure that it is communicated with your nurse and that the nurse have that on paperwork. Because come a time the family member comes, you say, "How come my mom is complaining that you never have any showers or so?" Oh, especially this day, this day, this day. Okay, let me go back to my. Oh, she refused here because she was sleepy. She refused here because she said this and that. So you have your documentation to back you as a staff worker. So same to what the video was saying earlier, we just have to make sure that we covered all our bases. Come a time that they need to come into investigation. So we have proof and support the sources. So can they refuse flu shot if they don't want a flu shot? So the patient, by the way, by rule, they have to sign a paperwork that I refuse to take the flu shot, so I decline. Now, what about the COVID shots? They can decline as well. However, again, it's like documentation will have to be there that they decline. So come anything that the staff members or the facility will get in trouble, they have something to go back to as a proof that the resident declined to this different type of treatment or procedure. So the question is, what if my patient is not able to cognitively decide whether, okay, I'm going to give approval or consent, or I could refuse because our president might have dementia. So what are we going to do? Anybody? Okay, family member or speak to the doctor. Okay, people at the homes. What do you think we do if real resident Miss Mary has dementia and will not be able to speak for herself? And if she does, that will not count because she has mental or cognitive impairment. Get the nurse, Sabrina. Okay, to be more specific, ladies and gentlemen, the family can also help, but they need be uh, to be declared as the special power of attorney, the DPOA. Yeah. So we're going to be talking about that in a bit. So there has to be someone who's going to represent this family member who's not able to decide, especially for the advanced directives. What is that? It is a paperwork that tells whether come in a time that there's distress or that resident needs emergency assistance. Should we pursue with a DNR, meaning do not resuscitate, or full code? Full code meaning do everything to revive the person. So it has to be signed because, California, we need everything to be in black and white. It needs to be on the paper. They cannot just rely on what was said, what we heard, or it has to be on paper. Yeah. So especially in the healthcare industry, when people sue people, yeah. So you need to protect yourself too. So anyway, the next one I have here is to accept or refuse any proposed treatment or procedure. So they cannot just refuse or provide consent. They need to know why and what are the literature. What will help me decide whether I'm going to give my thumbs up or a thumbs down to the specific procedure. For example, the doctor says, okay, today, Miss Mary, it will have to be a colostomy bag to be installed, or there's going to be an endoscopy because we're going to look into what's happening in your bowels there, all those things. They need to know first, should I allow that or no? And if I can't decide, let me involve my DPOA so they can help come up with a decision whether should be a go or not go, or maybe not yet. Those kind of things. There will be events where the resident might have some really severe diabetes, and the diabetes has crawled all the way down to the leg. And for all reasons, and it can become really worse, it will begin to consume the leg going up, and it will be a toxin. So the intention is we're trying to save the other body parts by amputation. So the family will now decide, will we allow that? We don't want our mom or dad losing or get their leg chopped off or amputated. Or, but if we keep that and still have that limb, there's also a chance that it will become worse and can infect the other body parts. So it's going to be a dilemma. It's going to be a question whether should we go or no go. So we have a thumbs up or a thumbs down in this type of situation. So the job of the doctor is to provide all the documentations and give all the data available and maybe even a good amount of education so they can lay down on the table and think about it as a family, whether it's a yes or a no. And same through what if that is a psychotherapeutic drugs. And what are these? These are more like chemical restraints. What are these is, for example, Mr. Mary become unsettled, and she could be rowdy. She could be hurting herself, hurting other people, destroying properties. So the doctor would try to assess what is the level of this situation, and then she could say, okay, you know what, Miss Mary, or family of Miss Mary will have to introduce a new medication. It's called Ativan, clonazepam, or it's going to be Haldol to keep her, a little bit sedated, calmer. So, or Xanax. So what's going to happen is, okay, they think about it. So they're going to just randomly, okay, for the convenience of the nurses, because we don't want the nurses to be going up and down, running after a family member. Here is Ativan. So it's also subject for abuse. And Ativan, ladies and gentlemen, with the most that a resident can receive that will be 4 times in 24 hours. So they will not abuse that. For example, Miss Mary's been rowdy today. I don't want to take care of Miss Mary. Give him 4 Ativans, right, and 1 pop. And then another one after 2 hours or so. It's going to destroy that person's. Yeah, it's sad, my friend. And there will be events that resident could be acting out or behaving in a certain way. For all you know, my friends, it doesn't need to have that Ativan or any type of medication. Maybe she just needs to go to the bathroom. Maybe she needs to get some attention. Maybe she just needs to talk with a family member, and it will just diffuse and de-escalate the situation. And we can be that bridge. We can allow Miss Mary to access that opportunity to not get to the level when he is more of unsettled. A lot of that, to be honest with you, can be cured by having a little good chat, a little good talk, a little good breakfast, a good treatment, my friends, a good approach by a nurse, a CNA. If you are a CNA or nurse, you approach the patient, and then you come up to your patient with a more grudging and you're negative attitude. You come in and you're like bossing around, and you are just demeaning the patient. What does that mean for the patient? Oh, okay. They will have to respond as well in a certain way. And then when they respond in a certain way, the CNA or the nurse, they get it differently. God, Mr. Mayor became combative now. So wait a minute, maybe it was your approach, because a lot of times our patients, they mirror, they can see what's going on with you, what's your aura, what's your general constitution when you come to the workplace. That's why whatever issue you have in your head, in your mind, in your family, at home, in your car, with your dog, with your president, or your boyfriend or girlfriend or so, don't lash it out onto your patient. Don't vent it on your patient, because he has no idea what's going on. For all you know, like I said yesterday, they have much, much crazier things going on. Are you raising your hand or just stretching? Both. Okay. So anyway, my friends, it's very key in there as well. So it's usually going to be the nurse or the doctor who will explain about what will be the consequence if the patient will not take this specific treatment or medication. Like, okay, Miss Mary, if we don't amputate your leg, then it will go up, farther up, and it can consume your whole entire leg. And maybe you can move on to the other leg or so. So then they will come up to a decision. So the next one is going to be number 6. So be transferred or discharged only for medical reasons. So the residents can also be discharged in maybe different reasons. One of them will be because she has become well. Now she has improved a lot that the family can already take care of them. Going back to why are they in the facility? Because out from the hospital that they came initially, the hospital already decided that, okay, you guys don't need our services anymore. You're ready to go home. Of course, you're not totally well. Your wounds are still there. You still have broken limbs or so, but you don't need us anymore. You should be able to go and recuperate in your home. So here's the question. Are the family ready? The family get their own family members with jobs. They have their kids, and no one's going to be able to supervise, monitor, or take care in general. Their mom and dad who just arrived, and usually mom helps in with cooking food or going on gardening and doing things. Now it's going to be an extra baggage for that family. So what do they do instead? They take them to the nursing skill facility. That's why we have the SNF or skilled nursing facility. That's the institution. This is the place that bridges the gap between the hospital and the home until they become way, way better. And then due to a lot of rehabilitation activities, then they can go completely on their home when they are trained to do things independently, which is a little bit more of a challenge because sometimes two things can happen. They become better or they become. There are incidents that the resident comes to the facility, skin intact. Intact meaning there's no abnormalities, there's no wound, there's no bruises or things. Go back home, there's a brand new, huge pressure source. There's this, there's bruises here, there's broken in this, and before they can walk 10 steps, only 2 steps, maybe not even able to walk. So all those things can happen depending on how they are also cooperative during the treatment events. And of course, like I said, many things, many other factors can get into play. And this is why our role as staff worker or healthcare representative is crucial to help these souls in there. So if you go there, imagine this, if you don't have that heart to help the patient, then the way you act, the way you talk to them, the way you provide care will define the inside of you. It reflects your personality. It reflects your demeanor. It reflects your mental model, your paradigms about working with patients. So, my friends, I would usually suggest and recommend that at this point, I've been opening all these cans. I'm opening and laying down on the table all the cards. I want you to decide already. Is this something that I want to do? And please don't give them a cold shoulder and don't snub them because the patients are waiting for you there. May not have to be in the facilities, not all the hospitals, maybe on a one-to-one basis. And like I said, after you graduate here, you can decide to work as a home health aide, only work with one person. And for all you know, you can also be rewarded at some point. Remember, I asked you one time, I think the first day, this lady working as a a caregiver, they eventually there was a natural death on the patient, and the family rewarded $100,000. Boy. And of course, I mentioned that you will not be choosy in picking your patients. You don't have your own screening factors, and you have your also criteria for screening your patients. Now, if somebody needs help, jump in and help. So, how much money do you have in a bank? Oh, okay. So I'm gonna hop in and move on to the swipe left. No, it's not a dating site. It's not a dating site. Somebody needs your help. You are blessed to be able to provide help. Remember, it's better to be a caregiver than a care receiver. Because if you are a care receiver, that means you are that patient. not able to do things on your own. Depend so much on other people to do things which you used to do them by yourself. So that's why, my friend, is very important there. Anyway, so many different reasons, including non-payment of her stay or to be given reasonable advance notice. So the resident will be discharged, will needed to be aware about how many more months that they're going to be staying. It could be because of non-payment or so, and then so they can approach the social services and provide extra extension or so, whatever that be. Okay, I'm going to go down here and proceed. I actually purposely highlighted this or presented this in more like a different letters, color, font color you have to exercise rights as a patient and as a citizen and to this and to voice grievances. So the residents themselves, my friends, amigos, amigas, they can also vote. They can go out and elect the president of the United States. Could be Harris, or it could be Trump, or whoever is going to be in the presidential race. Not only that, they can also present themselves in the form of complaints or grievance or a commendation. So, but if they are able to get out there and voice out what they might be experiencing during the stay, or maybe even it's about policies like, okay, we would like to extend our visiting time from 9 a.m. We want it 8 a.m. So when we wake up after our breakfast, we already see our family members. We will not wait another hour in this place. So they can have that if they wanted to, because remember, they are called residents because they live there. We, as caregivers, CNAs, as nurses, we go there as professionals. We are visitors. We are healthcare help provider that will go there. But depending on whether they need us or not, they take and they have the ball. They call the shots. Okay, the next one is going to be free from discrimination based on many different factors, including gender, sex, race, color, religion, ancestry, and you have the list there. So no discrimination. That's what is basically about to say, regardless of where you came from, whether who you voted for, whether how do you pray, with your religious belief and affiliation, whether what kind of books you read or not read, whether what kind of hair you have dreadlocks hair or so, long hair, short hair, or many other things that can be get in the way. Whether that resident is obese or not obese, or are skinny, or 350 pounders, or married or not, or person with crazy amount of tattoos, we cannot discriminate. That person comes up to us and that person is under our care, we will provide care and hold on to your own personal stereotypes, because you can also have your own stereotypes. Okay, this is a Mexican, I have my own stereotypes. This is Filipino, these Filipinos are loud. They have to, and they can be loud. And remember, they come there, hey, good morning, do you want me to eat? Have it, bring some food. Oh, oh, that was God. So, yeah. Wow, thank you for the laugh. We needed that. So anyway, those, my friends, we will not discriminate. Even if the patient that comes up to you looks like your high school teacher that you don't like a lot, still provide the care. Or your ex-boyfriend who cheated you 20 times. That's a lot, by the way. Still give them care. Everything's okay, right? Okay, to manage personal financial affairs, and I showed you earlier, there could be a possibility that a patient money or credit cards or so can be abused as well. Now, here's a question about how much money are they allowed to take along with them in the facility as soon as they get admitted. What do you think? Give me a good guess. About how much they're allowed to be in their person? $10. 20 bucks. You're correct. Actually, 20 bucks is the ideal amount of money that they can have them in person. And maybe if they bring in like maybe 1,000, they can still bring it, but they have to deposit that to the facility. Like there's a group there, maybe the social services group, or maybe even the activities department, and they can keep the money while they are there. They can, of course, withdraw some amount of money every now and then in form of petty cash. But definitely in their person, which that makes me remember my grandma, that she has this handkerchief or like a bandana, and they put the money in there, and she wants it on $1 bill. She goes to sleep, she counts it first, Hello, $1, $2. And she gets to remember every serial number that's in there. Before she goes to sleep, she counts that, and then she would tie nuts in there, like 20 different amazing, like really hard to decipher nuts. And then she gets up, opens it again. Hello, world. Opens it again, start hunting them one by one. You're all complete, boys. And then it covers back again, go on with their life. Some of the patients also have that type of hang up, if you will. They have that kind of behavior. They have that kind of safety net or a kind of connection. And they feel that they're the wealthiest patient in the universe. Ha, I got my $20, and they use like all the 20s like fan. And you're like, it's kind of warm here. So this is true. Sometimes at one point, this patient has those $1 bills, and then two of them begin to get crumpled because everyday use. And like, oh, can I get to change this where the ones that's really crispy and brand new? You can smell the printing press still in there. And so, yeah, we can allow that because that's their joy. We cannot just take it away from them. And this is why they are so upset when they wake up one morning and they cannot find their monies. They're gone missing or misplaced. And then sometimes, oh my God, the last person who came here was Gonzalo. And she came along with a really thick pocket. Maybe that was my money. Well, that was just gloves in your hand, in your pocket, or so. Or maybe that was the burrito that you did not finish during lunch that you put in your pocket. So, but of course, the resident would like to point at possible anything that they think that the money was been taken out to. Maybe a CNA, maybe a nurse, or maybe a roommate. Now, because of that reason, to avoid the frustration of Miss Mary, it can go for how many days, and she will not be able to function well. The facility can replace that because it's $20 only. So imagine if there's 1,000 in their pocket and it's gone missing. That's gonna be a little harder for the facility to replace. Yeah. So 20 is okay. Now, if resident wants $100, they will evaluate first. What's the functional level of this patient? Is she able to keep this amount of money in her person? Does he have a way to keep that, or the roommates are will not care about that? So, and then they decide, okay, then that's fine. And they might have to sign a little waiver, like if it's gone missing, they will have to do these steps instead of how come every week it's gone missing? We spend already 2,000 almost every week to replenish the amount of money. So those, my friends, again, can they have their own credit cards and debit cards? The answer is yes. As a matter of fact, they can go on DoorDash and buy food for themselves. True. Why would we stop them, dude? No, let's not stop them. But there's some limit, and there's also some type of we would like to moderately someone monitor what's going on. We don't want that person to be going beyond what's on the diet program. Remember, they have the diet program, and that person keeps buying all those greasy type of food here and there every time. Hospital food? No. DoorDash. So if that happens every time, the dietitian will like, wait a minute, what's going on? It's gaining weight. It's gaining weight all because it keeps on going on DoorDash. So what they do now is before it's being delivered to the patient, it can come pass first to the nurse and take a look at it as well. Okay, this is good. I think once in a while should be okay, and not every time.
Yeah, do they get to change their money back?
What is this? They order on DoorDash and then this was not what it is, and now I have my lunch. Is that what it meant? Thank you, patient. You got all my favorite food right here. I don't even have to order anymore. So what's going to happen is maybe that one they can get mention that to the family members. Hey, you know what? Your mom here just ordered this and they get the food here. So we can. This is the last time we're going to give it to her. That's for example. That's the last time we can allow her. But next time we will we will be able to intervene, or maybe we would just there's also a pattern. Maybe sometimes they also like to go to Jollibee, this kind of thing. They will kind of look at it and they will document that or report. Or maybe they can ask the family members, what do you want us to do with this? And we can deliver it to you. We can ask this delivery person to change the address instead of here, will be to your house. Or I can take that too. That's Jollibee. Is it spicy? But anyway, those things, my friend, we make things much more convenient for them, but not to hurt them, or now will not become more worse in terms of the diet program that's given to them. So they're also allowed to. Some of them may still have some businesses going, because it doesn't mean that if you are a patient, you're already cuckoo or you already have some mental cognition. They can still manage things. Some of them still manage cars or so. So we allow them to have access to that as well. We will not stop them. And be aware that one time I've worked this facility, this is a he, and he has a car. So what he wants is he brought the car along with him in the facility. So it's parked outside. Well, here's the thing. He cannot drive anymore, but he was on a wheelchair because, he got some type of hip fracture or so. Guess what? Every morning, and I see him, this passes by, so we allow them to come out because he's in a wheelchair anyway, and he's within the line of sight. He would talk to the car. He would bring some pail and clean them and talk with them every day. And sometimes we allow them to get inside someone to rev the car at least. We want the car engine to be moving and not being stuck. And sometimes we allow them to move the car a little bit forward or backward to move here from, I would say, parking spot A to parking spot B, just to get that connection with what they value, treasure most. And it's very painful to see that. It's just moving to see them that they're going to be talking in the cars, like, stroking the car and really, as if the car talks back to them with the sunshine, and then you can also tell them about what their experience was, and they talk about your car, how do you feel, etc., etc. So they have coffee together with their car. They bring a cup of coffee, and sometimes they hang up in there on the wheelchair. Sometimes, and they like the sunshine, so both of them get the sunshine. So that's just moving when you see that, and that's why we allow them, because we can't stop them. That's the only way for them to still remain connected with with those things, people, events, or whatever that is that matter to them. So number 10 is to be free from mental and physical abuse. So we talked about that. We don't want any sort of inappropriate behavior or the way we approach the resident. We have to be, of course, respectful at all costs. So no mental or physical abuses, and you hope all those abuses potentially. And I think as we go forward, this is not only for patients. This is all true with everyone we know, whether it's a patient or a regular individual. So to be assured of confidential treatment of financial and health records, to approve or refuse a release except as authorized by law. If you remember, you go to the clinics, they ask you to sign a paperwork. Disclaimer or something like that, you allowed to release your medical records if it is from hospital or physician to physician. And so release form, that's your medical release form. So they also have a way for that. So to be treated with respect, recognition, dignity, of course, I talked about this earlier. It's about individuality as well. Privacy of treatment in care of personal needs. So it is very important that when we approach the resident and we know that there's going to be a surgery for Miss Mary, we will not go inside Miss Mary's room and screaming from right the door side, Miss Mary, you have a surgery tomorrow. They're going to chop off your leg. And then there's Miss Linda on the side and Miss Christina on the side. Oh my God, Miss Mary, they're going to chop off your leg. It's going to be painful, dude. So they're going to be teasing Miss Mary. So we don't. As a matter of fact, we will, in this really critical kind of procedure, you'll be taken along with the family to one private area. Because even if you are very, very controlled voice, a moderate voice in there, the only item that separates from bed to bed is a curtain, and it's going to be a thin curtain, and it doesn't block the sound. They can overhear what's going on, and sometimes they're quiet, but they're also listening what's going on. Okay, I'm gonna go down here. Do not to be required to perform services for the facility. So of course there will be a different type of activities, treatments, and interventions, it have to be in the patient's care plan. If it's not in the patient's care plan, we don't have any business to perform that. Wait a minute. If it's not part of your treatment plan, what's the point? Maybe the facility want to rake extra money on the bills because guess what? How much is the physical therapy activity? I'm going to give you an idea. A physical therapist will get paid about $70 to $90 an hour, right? So that's just a physical therapist. Now they have to pay. Who's the boss of the physical therapist? They have to pay for many other things just to do that activity. So we will not be inventing or coming up with some sort of activity just to get money out from maybe not from the actual pocket of the patient or the patient's family, maybe from the insurance company. But still, that is not ethical to be in that type of situation. So number 15 is to meet with others and participate in activities of social, religious, and community groups. And like I mentioned earlier, they can be on Facebook too. They can be on TikTok. They can be on Instagram. As a matter of fact, I have a follower who's also a patient, and he likes to give comments or answer every now and then. So yeah. Okay, so we already watched the rights and communication video earlier. But anyway, they can have their own laptops. They can do their own vlogging if they wanted to. We will not stop them. They can be a what's this guy who has a lot of followers? They can be an influencer. Hey, I'm the influencer patient. Oh, talking about that, let me see real quick here. So this lady is on. Anyway, maybe I show it sometime. She is. She has colostomy bag, and she is not scared. She's a she. She's not very scared. Being on TikTok, and she's showing, "Hey, today I'm gonna replace my colostomy." And that lady is very just yeah, very, very brave and just very courageous not to. Some people are scared. Some people are, they're holding back because they're not aware or they're scared about what other people might think about those things. So number 16 here on my list is to retain and use personal clothing and possessions as space permits. It's going to be on the test as well. They can bring their own personal wall decoration and maybe even their own personal blanket, kumot, or a pillow or a pillowcase, or it could be their own Tempur-Pedic mattress. Yes, they can if they wanted to. They can have their own clothes and mark in the back their name, so it has identity who to assign this clothing. Come a time that they have to wash more, so those clothing. So that's very important, my friend. As long as the space permits. However, because the rooms could be small, if they wanted, oh, I'm a pianist, I'm gonna bring in two of my favorite grand piano. It could be too big in her. So now number 16, to retain and use personal clothing. Yes, ma'am. Yes, sir. The thought, remember that story yesterday or the day before? You could be wearing that gown worn by 5 people in the past who died in many weird deaths. Some of the freak accident death. And now he's going to be wearing that. What is the stain in here? Oh, maybe the spaghetti. So that was a blood from another person who wore it. True story, my friend. Are they going to throw that? They toss that to the soil linen basket, and then they're gonna clean that. Of course, they will bleach that somehow. They will get that washed, but there's a spirit there already who dwells in there for every threads. And there's many different stories. Whoever wears this would feel different, and that is why maybe some of the patients acting weird. True story. What? Sometimes she's walking differently now, and oh my god, she's floating about 4 inches off from the floor. And then she's walking like the oh no, how come she's not blinking? So anyway, oh. So anyway, to retain and use. Okay, we got that already. Um, I like this school. You can be ordering your donuts while in the class. You can be in your car. Alfie, oh, this guy. Francis could be sleeping already at this time, and then she wakes up. It's quiz time now. Okay, okay. Quiz number one. A. You say A. Okay. A. B. 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 Okay. Francis, thank you for staying awake
Nah,
with me.
yeah, I'm awake all the time.
Okay, good. So there's a little bit of drool on your sides of your mouth, by the way. Can you wipe
I'm
it down?
awake. Yeah, I'm awake all the time. So just trying to
Wow.
minimize my face. I was trying to allow you to
So
enjoy the background all the time.
okay. All right, Mr. Francis. So anyway, going back here, number 17, if married or registered as a domestic partner, anyway, they could have someone that's really intimate with them. So we will not stop them. And they could also be doing some intimate things. Well, so it has we need to be aware of as well if there's a spouse in there, we can give them based on the policies, and that they can have some time together as well. And as a matter of fact, they can also be sharing the same room because there are events. The mom is in the hospital on the facility, and the dad is also there. They can be together. They can decide to be there or can decide to be okay. Even if we are married, I want to be on the other room. That's fine if they wish for that. As a matter of fact, in one facility here, the mom and dad work as the mom and dad are patients in this facility, and the daughter works at the activities department. So before the this lady goes home, she stops by at the rooms of their parents. Christmas time, they share that together. So those kind of things, and that's okay. So of course, to have daily visiting hours established, and we knew that's usually around 9 a.m. to 9 p.m. Usually, it could be 8 a.m. to 8 p.m. or 9 a.m. to 8 p.m. depending on the policies or protocols at the facilities. But yes, ma'am, yes, sir, they can decide whichever is helpful for the general peers in the facility or the clients or residents to have visits from members of the clergy at any time. The request of the residents on the patient representatives. So I'm going to go back here. Remember, we have established a time for visitors to come there, but for example, it's 9 a.m. to 9 p.m. However, 2 a.m., Miss Mary requests Francis. Francis, I want to see my priest. I want to see my padre. And then and Francis looked at Miss Mary. Okay. Also, he take a glance at his watch. It says, and the watch is 2 a.m. And he goes, "Sure, like that 2 a.m. We have a policy 9 a.m. to 9 p.m. What would you do, Francis?"
Ah,
Thank you. That's correct. So, well, what are you going to do?
that's great. Oh, okay. I have the residents. Well, I think the residents have the rights, and then
You remember, there's a policy, there's a
yeah,
protocol that's only 9 a.m. to 9 p.m. allowed visitors, and the priest is a visitor too.
yeah,
And Miss Mary really wanted to see her priest.
yeah. So I think basically the residents is aware of the policy of the facility, so and I think that is very important. But sometimes, I work with some residents, so they could be very stubborn, sometimes when it comes to enforcing some of these things. And then they would want you to consider their own rights uh
But what,
before,
Francis, what if
yeah.
this patient is your favorite, your most favorite patient? Will you sneak in the priest through the window or the back door? What would you do?
Oh, well, I think basically I wouldn't allow anybody to enter the facility. Once it's past the time that is given. So just for the safety of the every other person in the facility. So I wouldn't allow that. So
Atigora, what do you think, Miss Carol?
Um, hold on, hold on. Um, so if the patient is like number 20, if the patient is critically ill, then I would of course ask the nurse or my immediate supervisor that the patient would like to
What
see
the
her
priest?
her priest or his priest. But if the patient is not critically ill, then I would just explain to the patient that there is a policy. It's only from 9 to 9. However, first thing in the morning, we will be contacting your priest, and we'll make sure that he's gonna visit you
Mm.
soonest.
Okay, that's also a good answer. Let me
I
thank
I
you,
I
Francis.
also
And
I also have I think, well, there could also be another way for her to speak to the priest. So I can volunteer to connect both of them via telephone, so the priest can talk to the residents. So I think that's an option. So I
okay,
could I
that
could
is an option. Yeah, they can
yeah
do
I could
FaceTime, right?
I could
They
suggest
can.
that. So yeah.
Mm. Okay, very good. We're very creative and resourceful, and making sure that we also provide that right to the patient. Listen up. So it was 2 a.m., Francis, and then the Miss Mary once really insists, I want to see the press, and of course, Francis also insists, okay, you just go on FaceTime or so. Number 19, to have visits from the clergy at any time, because what if the resident expired at 4 a.m.? He's gonna be chasing you in your dreams, Mr. Francis. You did not let me talk about Krish. Now I'm in hell. I wanted to have a confession to why my soul will be saved. Francis, you are the culprit. I'm gonna make your life miserable now. So that's the thing. Because we don't know. You might want to have that's the last priest visit. And then you stop him or her to be able to get a chance to do her last confession. So if it is a priest or a padre or a clergy, a pastor, number 19, they're allowed to. I think we're allowed to. It's like anybody else. What about you? Are you going to speak with the priest? Make it happen, right? We will not be in there. So that's going to be answer in there, my friends. Number 20, to have a visit from persons of the patients at any time. This is when the resident is critically ill. Maybe he has COVID or so. We use that, or many other diseases or illnesses, conditions that can become contagious, and it is contraindicated. So we have to just manage that to avoid spread. 17, we have that already. Going here and okay, a couple more. To be allowed privacy for visits with family, friends, clergy, social workers, or many other people for different reasons. Could be personal, could be business related, work related, or just for social interaction. So to have a reasonable access to telephone, and I mentioned earlier, can they have your cell phones? Yes, ma'am. Can they have their favorite rotary phone, which you dial like you rotate it? Yes, they can. They wanted to, and that's why we will have to allow them have access to those communication facility. Can they can talk with the family members, pick up calls, receive, create, make outgoing calls, or maybe even on personal mails and emails. True. To be free from any requirement to purchase. So, drugs and other medications, they will not be forced to buy. They will not be forced to use their high-end, high, most elite type of wheelchair. If they need a wheelchair, it's a regular wheelchair will be fine. So we cannot force them. Oh, you should use this fancy, this amazing, and this fascinating high-tech AI controlled wheelchair. We don't have to force them to have that when they don't need it. And whether they buy it or rent it, this should be the based on the discretion of the family members or the patient, because sometimes wheelchairs will be only used for some time and not for the entire event. So it depends on them wherever they want to access that. If they want to buy from Amazon, the generic brand, or they want to buy it from a more expensive signature brand, we have no right to force them or coerce them to get those. To be free from, we mentioned sometime a little while back about psychotherapeutic drugs and physical restraints, but generally to be free from any of those physical or chemical restraint. So physical restraint is you put them in one corner or have them immobilized or so, the physical way. The chemical restraint is still immobilize them or get them sedated or have them just flat on the bed with the use of some medication to tame or to get them settled. So, okay, so we're almost done here, ladies and gentlemen. Advanced directives is a way for the patient to um, express whatever it is that they want come a time that emergency happens. So provides instructions about the wishes for the treatment when the patient is unable to do so. So that's good. Full code. What is full code? Full code is okay. Full code is we do everything to revive the person. Full code. Do CPR. Call 911. Call Monkey Pueng. And do your favorite albulario. Everything we can do just to revive this person. The DNR, though, is do not resuscitate, meaning whatever happens to the resident, if don't be tempted to call 911 because she requested to just give him a comfort care. Maybe put a pillow, maybe keep her safe, maybe put her on the bed or so, and make him feel comfortable. But that's all we can do. We will not initiate CPR. We will not call 911. So because that's what her wishes. Again, potential reasons could be just like 4 different cancers, and there's no hope that this person can prolong her life. And this person have 20 different pains, back pains, headache, arm pain, etc., that are chronic and constantly giving him a hard time with every day-to-day scenario. So and then, of course, no family members. And they keep on paying that facility. They keep on paying that hospital and then sucking in all their monies just for, there's just no hope for any type of becoming well. So screw that. Just let me go. So full code. Now the no code is to be treated as full code. So what does that mean is like I am no code. I mean, do you guys any have of those? We don't didn't sign any of those. When you become to the facility, you will be asked to sign that because come something happens, they know how to respond to whatever it is that could occur over there. So again, that is going to be full code in general and then DNR in general as well. But no code will be treated as full code as well. Okay, so that's what we call the advanced directive. So I'm going to go down to the next one is the advanced directive is called to be the POLST. That's the more technical way of calling that. So I'm going to pull up here a picture of what we meant by that. So this is going to be a POLST form California. Just to give you a heads up and give you an idea how it looks like. It's going to be a pink paperwork, and I'm going to pull up this one. Let me expand this a little bit bigger so you can see that and make it a little bit bigger so we can further see what's happening. So there it is. It up here would say, do not attempt resuscitation or allow natural death. And the resident will tick this box here indicating that anything that happens, let's allow natural death on me. Or it could be attempt resuscitation, attempt CPR, requires selecting full treatment. And then at the bottom, you can also have to get the signature of the patient and at the same time, the physician. So 2 signatures should be there. It cannot only be with the patient's wishes only. It has to be acknowledged, recognized by the legal representative, which is the physician. Now, like I said earlier, what if the patient has no capability of cognitive decision-making processes? So there you go. That's your DPOI, the durable power of attorney, who's going to represent that patient. And that person will be in charge of decision-making. Maybe it's not a DPOA, maybe it's the next of kin, maybe it's the most family members, but it has to be recognized. So it cannot just be a random. So one here, someone signs here, another sign here. So this is going to be consistently with this person. Okay, because there are events, some other individuals, they don't have family members. So they will could be a close friend that can represent for that one. Okay, I'm going to go down here. The durable power of attorney, remember, we mentioned about earlier, is a person appointed by the court authorizing treatment or decision-making or any of those life-changing or that kind of decisions that could be big enough. So that's a durable power of attorney for healthcare. Okay, that is what I'm going to show up to you guys. We passed that already. The omnibus budget reconciliation Act of 1987. So, incorporated into federal law, the rights of the patients or residents in long-term care facilities. So, this usually happens definitely in the long-term care facilities, skilled nursing facilities, elderly homes, nursing homes. There are generic terminologies that we have for them. So, the OBRA, which is Omnibus Budget Reconciliation Act, is going to be that body or this organization agency will be in charge with that one. So again, the patient's bill of rights is a written information being provided to all patients upon admission. These are the rights. Remember at the very beginning, number one, the patient needs to know what's the situation there. The patient needs to know what are the different obligations or protocols, policies that they need to abide with, and upon admission. As a matter of fact, ladies and gentlemen, if the resident is admitted at the facility, they already know that if the resident expires, it's going to be our terminology, if the resident dies, they already know where to take the body. So what if 5 minutes upon admission, the resident just suddenly died there? So they need to know where to take the body. Okay, and we have a separate module for that, which is death and dying. So the healthcare personnel should also be aware of. So not only the patient is aware, what about the Bill of Rights of the patients, but also every individual in the healthcare team, they should be aware of.